Tucked deep within the retroperitoneum, lying tight against the curve of the duodenum, the pancreas is an organ that demands absolute respect. Because of its complex embryological origins and shared biliary drainage system, a localized failure within this gland rarely stays local. An issue here rapidly cascades into a systemic catastrophe. For decades, surgical intervention on the pancreas was highly invasive and carried massive mortality. Today, that brute force approach has been replaced by strict algorithm-driven damage control. Look at this contrast-enhanced CT scan. The dark, non-enhancing areas within the gland indicate complete tissue death, a hallmark of severe acute necrotizing pancreatitis. And here is the other extreme. This endoscopic view shows a raw, protruding ampullary carcinoma directly invading the duodenal lumen, a silent neoplastic failure. Mastering pancreatic care requires strict adherence to 3 clinical pillars: understanding developmental ductal anatomy, utilizing the step-up approach for necrosis, and executing precise oncological resections. The mechanical root causes of lifelong ductal pathologies begin in the 5th week of gestation. At this stage, the pancreas consists of 2 completely separate structures, the ventral and dorsal buds. The ventral bud arises from the hepatic diverticulum, rotating around the duodenum to fuse with the dorsal bud. This determines adult anatomy. The ventral bud becomes the head and uncinate process, while the dorsal bud forms the body and tail. When the parenchymal tissues fuse but their respective primary ducts fail to connect, a condition known as pancreas divisum occurs. It is the most common anatomical anomaly of the gland. In divisum, the large dorsal duct is disconnected, forcing most exocrine fluid through the undersized minor papilla. This narrow aperture creates a structural bottleneck and obstructive pressure. Therefore, divisum must be excluded in patients with idiopathic recurrent acute pancreatitis. Beyond the ductal architecture, the main drainage exit adds another layer of clinical risk. The sphincter of Oddi functions as a sophisticated physiological barrier governed by multiple integrated muscular zones. As shown in this cross-section, it is composed of 4 distinct muscular layers: the superior and inferior choledochal sphincters, the ampullary sphincter, and the pancreatic sphincter. Dysfunction in any one of these zones can block outflow. The blueprint of the pancreas is laid down in the first weeks of gestation. Any deviation in that timeline establishes the mechanical triggers for catastrophic inflammatory cascades decades later. When those inflammatory cascades trigger an acute pancreatic crisis, the diagnostic sequence must be rigorous. The initial biochemical baseline is established by measuring serum lipase, which is highly specific for pancreatic autodigestion. Next, a transabdominal ultrasound is the mandatory first-line imaging step. Its sole purpose at this stage is to identify or rule out gallstones as the trigger. However, ultrasound cannot stage the damage. To assess severe local complications, contrast-enhanced CT is the absolute gold standard. On this CT scan, focus on the pancreatic parenchyma. Zones of reduced enhancement and peripancreatic stranding confirm acute necrotizing pancreatitis. Applying the Glasgow or Ranson scoring systems, a score of 3 or more dictates aggressive, monitored care. Historically, when that necrotic tissue became infected, the standard response was an early open laparotomy. That approach carried massive surgical morbidity and was frequently fatal. This image of an early surgical theater reflects an era where operating on a highly inflamed retroperitoneal organ often did more harm than the disease. Today, the standard of care is the step-up approach. Step 1 relies on placing a percutaneous drain into walled-off necrosis under image guidance. We only proceed to Step 2, a minimally invasive or formal surgical necrosectomy, if sepsis persists despite adequate drainage. When necrosectomy is unavoidable, the surgical philosophy is strict. It relies entirely on blunt debridement, painstakingly clearing the dead debris while sparing any viable bleeding pancreatic tissue. In acute pancreatic crises, modern clinical survival is maximized by actively delaying invasive surgical trauma and relying on stepwise, targeted damage control. While inflammation presents loudly, neoplastic disease is silent. Tumors located in the head of the pancreas typically reveal themselves only when they obstruct the bile duct, presenting as painless jaundice. This brings us to Courvoisier's law. If a jaundiced patient has a palpable, non-tender gallbladder, the obstruction is highly likely to be a ductal adenocarcinoma.
A gallstone would typically cause chronic scarring, preventing the gallbladder from distending. Beyond obvious masses, incidental cystic lesions require careful triage. It is an absolute clinical necessity to differentiate a premalignant cystic neoplasm from a benign inflammatory pseudocyst. This endoscopic ultrasound isolates a focal cystic lesion. Using fine needle aspiration, we safely sample the fluid without spilling tumor cells. Fluid analysis showing CEA levels above 400 nanograms per milliliter strongly suggests a mucinous neoplasm, mandating surgery. If a tumor is confirmed in the pancreatic head or ampulla and imaging proves it is resectable, the gold standard intervention is the pylorus-preserving pancreatoduodenectomy, or PPPD. This schematic illustrates the massive scope of the PPPD. We remove the pancreatic head, duodenum, and distal bile duct. By preserving the pylorus, we maintain normal gastric emptying. Reconstruction requires 3 high-risk anastomoses: the pancreatojejunostomy, hepatojejunostomy, and duodenojejunostomy. These complex connections carry immense risk. A postoperative pancreatic fistula occurs when pancreatic juice leaks from the anastomosis, a primary, potentially catastrophic complication that can erode nearby vessels. Even a flawless surgery is only the beginning. Resected ductal adenocarcinomas require aggressive adjuvant chemotherapy, such as the M-fulfarinox regimen, to meaningfully extend patient survival. Surgical oncology of the pancreas is a rigid algorithmic pathway. Massive, life-altering resections are only justified by strict preoperative staging and highly specific tissue diagnosis. Pancreatic pathology is inescapably dictated by its geography. From the rotational migration in the 5th week of gestation to the final suturing of a complex anastomosis, the location and structure of the gland determine the outcome. Whether a surgeon is identifying the bottleneck of pancreas divisum, placing a drain into walled-off necrosis, or executing a PPPD, clinical success relies entirely on precise anatomical targeting. We have moved past the era of reactive, broad open surgeries. The modern approach requires proactive, high-resolution diagnostic mapping before a scalpel ever touches the patient. Tools like MRCP, direct endoscopic ultrasound, and rigorous CT severity scoring are now the true gatekeepers of the operating theater. The pancreas will always remain an unforgiving organ. It severely punishes blind interventions, but it rewards strict clinical discipline. Mastering these diagnostic and operative algorithms forms the non-negotiable baseline for any medical professional managing biliary and pancreatic disease.